Good morning. I am Dr. Prachi Mital from Department of Conservative Dentistry and Endodontics. Today we will be studying about endoperio lesions. So coming on the introduction, what do you mean by endoperio lesion? That means when pulp and the periodontal tissues, they are closely related. Both in endodontic and periodontal lesions, they can affect the same tooth at the same time simultaneously. So they are known as true endodontic and periodontal lesions. That means they have infection in both the areas. So that as the tooth will mature, the root is formed, there are main avenues for exchanges of elements and other irritants, that is between two compartments are created. First, these avenues are dentinal tubules, lateral and accessory canals and apical foramen. So various pathways that connects the endodontics to the periodontal tissue are anatomical and non-physiological. Anatomical pathways, they can be apical foramen, the accessory and the lateral canals, and dentinal tubules. Whereas non-physiological can be due to iatrogenic damage, that is a damage caused by the doctor itself, and vertical root fracture. Now coming to various pathway of communication, that is how the bacteria transfers goes from endodontics to periodontal ligaments and periodontal to endodontics. So the bacteria transfer occurs via apical foramen, or in cases of vertical root fracture, it affects the healthy pulp and thus causes the pulp to become necrous. Once the pulp is necrotic, the microorganisms again travel to healthy periodontium through apical foramen, lateral canals, root perforations and vertical root fracture. From this healthy periodontium, the healthy periodontium becomes infected, and thus the series of cycle starts. So coming to in detail about dentinal tubules, they are basically exposed tubules which are devoid of cementum. Exposure of dentinal tubules, they can occur due to developmental defects or any disease process or periodontal or surgical procedures or interventions. When the cementum and enamel, they do not meet at cemento-enamel junction, these tubules may also remain exposed. Thus, they create a pathway of communication between the pulp and the periodontal ligament. Cervical dentinal hyposensitivity may be an effect of such phenomena. Lateral and accessory canals, they can be present anywhere along the root. Their incidence and locations, they have been well documented in both animal and the human teeth. It is estimated that approximately 30 to 40% of teeth, they have lateral canals and accessory canals. Majority of them, they are found in apical third of the root as shown in the diagrams. The accessory canal in the furcation of the molars may also be a direct pathway of communication between pulp and the periodontium. The incidence of accessory canal may vary from 23% to 76%. These accessory canals, they contain connective tissue, blood vessels that connect circulatory systems of the pulp to that of the periodontium. The accessory canal, they are most common in cases of apical third, that is 17%. They are less common in middle third, that is approximately 8.8%, and least common in coronal third, that is 1.6%. This is an accessory canal that we are looking in the second picture, which is at the furcation area. So these are basically also known as furcation canals when it is present in furcation area. This diagram shows the basic preoperative radiograph, which shows that it had already had an RCT before, but after some time it developed a lesion which was lateral to the root. Once again the GP was removed and it was retreated, there was finding that a lateral canal exited, and this lateral canal was completely cleaned and shaped and then again filled with thermoplastic gutta-percha, and then the lesion healed after 6 months. Apical foramen, it is the principal route of communication between the pulp and the periodontium. Bacteria and bacterial byproducts, inflammatory mediators in diseased pulp may exit readily through apical foramen to cause periapical pathosis. The apex is also a portal of entry of inflammatory elements from deep periodontal pockets to pulp. Pulp inflammation or pulp necrosis extends into the periapical tissue, thus causing local inflammatory response which is often associated with bone and root resorption. This is an SEM image of the apical third of the root. and thus we can see the major opening, that is the apical foramen, and lateral to that you can see at 90 degree there is a main small opening from the main canal. So this is an accessory canal. So when pulp becomes inflamed or infected, it elicits an inflammatory response of the periodontal ligament at apical foramen or adjacent to the opening of accessory canals. Noxious elements of pulp origin, including inflammatory mediators, bacterial byproducts, they may leach through the apex and thus trigger inflammatory response to periodontium. As long as the main canal is not seriously damaged, the pulp may not die. Now, what are the various organisms and infectious biofilms that are responsible for endoperio lesions? These can be bacteria, fungi, and viruses. These pathogens, as well as their byproducts, they may affect the periodontium in variety of ways, and they need to be eliminated during the root canal treatment. Now, bacteria. Bacteria, they play an important role in endodontic and periodontal diseases. The bacteria most commonly involved are proteolytic bacteria, which predominate the root canal flora, and thus they changes over the time to more anaerobic microbiota. Another microorganisms that are associated with endodontic and the periodontal diseases are spirochetes. Spirochetes are usually found at frequently in subgingival plaque, then basically in root canals. The spirochetes that are found are Treponema denticola and Maltophilia. Bacillus actinomyces comitans, bacteroids Forsythius, Echinella, Porphyromonas gingivalis, Privitola, Treponema denticola are also responsible. Found in endodontic samples and also in chronic apical periodontal cases. It is therefore appears that periodontal pathogens that accompany endodontic infections, and thus it is basically this interrelationship the critical pathway for both the diseases. Fungi, the most commonly fungi that are found in endoperio lesions are yeast and candida. Yeast colonization is associated with periradicular pathosis and untreated root caries, dentinal tubules, failing root canal treatments, apices of teeth with symptomatic apical periodontitis, and periapical tissues. Another possibility is that fungi may gain access to root canal from the oral cavity as a result of poor asepsis during endodontic treatment or post-preparation procedures. Viruses, the most common virus that is associated is herpes simplex virus, and it was detected in GCF and in gingival biopsies of periodontal lesions. Biofilm is also basically found in various endoperio lesions, and it is characterized by matrix enclosed community. It is found by mushroom-shaped colonies with some variation between the species. They are difficult to detect in routine diagnostic methods and therefore inherently tolerant to host defenses and antibiotic therapies. Non-living pathogens can either be extrinsic, such as foreign bodies, or intrinsic, including variety of tissue components. Some foreign bodies that are also being seen in endoperio lesions are basically dentine or cementum chips, previous restorative materials like amalgam, root canal filling materials, cellulose fibers from paper points that we use during root canal therapies, gingival retraction cords, leguminous foods, or calculus like deposits if patient doesn't maintain cleanliness properly. A foreign body response may also occur in any of these substances, and the clinical reaction may either be acute or chronic. Therefore, clinically such conditions may either be symptomatic or asymptomatic. Mechanical or surgical removal of foreign body is usually the treatment of choice, and it should be done whenever we find some foreign bodies in the gingival pocket or in periodontal apparatus. Other foreign bodies that can be isolated are Rushton hyaline bodies, epithelial rest of Melissus, Russell bodies, cholesterol crystals, and charcoal ladle crystals. Now coming to various contributing factors to endodontic lesions in the periodontium. Inadequate endodontic treatment. Suppose the endodontic procedures are not carried out properly, or when they're assessing the retention rate of endodontically treated teeth, it has been found that the non-surgical endodontic treatment is predictable procedure with excellent long-term prognosis. It is imperative to completely clean, shape and obturate the canal system well in order to enhance successful outcome. Poor endodontic treatment allows reinfection, which may often lead to treatment failures. So, in this first picture, we can see there is a preoperative radiograph showing a root canal treatment, but there was a big lesion in the apical area. Once we again properly cleaned and shaped, we can see the lateral exit, which were not completely filled, and the ledge was not managed. So once the ledge was managed and the lateral exits were completely cleaned and shaped and obturated, the lesion reduced in size and the tooth is completely healthy. Again, then there comes the coronal leakage. Coronal leakage is basically the leakage of the bacterial elements from the oral environment, which along the restorative margins to endodontic fillings. The root canals, they may become recontaminated by microorganisms due to delay in placement of coronal restoration and fracture of coronal restoration of the tooth. So we'll be continuing again with another reason why does this occurs. So trauma. Trauma to the teeth and the alveolar bone may involve pulp and the periodontal ligament. Both tissues, they can be affected directly or indirectly. Dental injuries may also lead to endoperio lesions with enamel fractures, crown fractures with pulp involvement, crown root fracture, avulsions. So, thus treatment of traumatic dental injuries also determine the pulpal and periodontal ligament healing process. Now coming to another topic, that is resorption. Resorption is also a condition in which can be either physiological or pathological, depending and result in loss of dentine, cementum or the bone. Non-infective root resorption or infective root resorption. Non-infective can be transient, pressure induced due to some pressure, chemical induced due to some use of chemicals, replacement resorption and invasive cervical resorption. Infective can be external or internal. So this is the resorption, and we can see in this picture it was treated and it was filled with MTA or biodentine and then again filled with the the tooth was obturated, so we could save the tooth. Perforations are also undesirable clinical complications that may lead to periodontal lesions. When root perforation occurs, communication between the root canal system and either periradicular tissues or oral cavity may often reduce the prognosis of the treatment. Root perforations may result from extensive carious lesions, resorptions during root canal instrumentation or post-preparation. Treatment prognosis of root perforations, it depends on size, location, time of diagnosis and treatment, and degree of periodontal damage as well as the sealing ability and biocompatibility of the repair material. It has been recognized that the treatment success, it depends mainly on immediate sealing of the perforation and appropriate infection control. Several materials that have been recommended to seal the root perforations are MTA, Super EVA, Cavit, IRM, glass ionomer cements, composites and amalgam. Today, MTA is most widely used. For differential diagnostic purposes, the so-called endoperio lesions, the best classified as endodontic, periodontal or combined diseases. They are again classified into primary endodontic disease, primary periodontal disease and combined diseases. So the combined diseases are again subclassified as primary endodontic disease with secondary periodontal involvement, primary periodontal disease with secondary endodontic involvement and true combined diseases. Now what are primary endodontic disease? Basically, there is an acute exacerbation of chronic apical lesion in the tooth with necrotic pulp that may drain coronally through periodontal ligament into gingival diseases. This condition may mimic the clinical presence of periodontal abscess, but it is a sinus tract from pulpal origin that opens through the periodontal ligament area. For a diagnostic purpose, the clinician inserts the gutta-percha, he tracks it with the instrument and into the sinus tract and a radiograph is taken. to determine the origin of the lesion. When the pocket is probed, the pocket is narrow and it lacks width. Thus, after just treating it with only endodontic therapy or root canal therapy, the lesion heals. And complete healing can be seen after 6 months as seen in the radiograph. So, this is the primary causes, only the non-vital pulp. Then, a periapical lesion of endodontic erosion will not occur in presence of normal vital pulp. So, pulp needs to be non-vital in such cases. So, that's why the name suggests primary endodontic diseases. Similarly, seen in the radiograph, we can see the pocket depth which is narrow. Once it was again treated with root canal, as in third picture that you can see, after healing, the probe was not able to go inside the pocket. So, the buccal defect was healed and pocket probing depth was normal. Then comes primary periodontal diseases, that is, which is caused by primary periodontal pathogens only. So, chronic marginal periodontitis which progresses apically along the root surface, pulp test will remain vital, that is, will be positive. There can be accumulation of plaque and calculus can be seen. The pockets are wider as compared to primary endodontic diseases. So, once the vitality, and you can see a generalized bone loss, as seen in this picture, the interior there is generalized bone loss. So, the treatment will be surgery, healing of the pocket, and the tooth remains vital. So, there is no need for doing root canal therapies and it is completely healed. Combined diseases. Combined diseases are those diseases where primary endodontic disease can occur with secondary periodontal involvement, that the disease started from the root, from the tooth itself and progressed into the periodontal apparatus and thus involve the periodontal tissues also. So, if after a period of time there is a suppurating primary endodontic disease which remains untreated, it may then become secondarily involved with marginal periodontal breakdown. The plaque it forms at the gingival sulcus of the marginal sinus tract and leads to marginal periodontitis. The tooth now requires both endodontic as well as periodontal treatments. If the adequate endodontic treatment is done, that is root canal therapy is done, proper cleaning and shaping is done, and filling is and the tooth is obturated, then the part will heal to the level of secondary periodontal lesions. Healing of the tissue damaged by suppuration can be anticipated. Primary endodontic lesions with secondary periodontal involvement may also occur as a result of root perforations, where pins and posts have been misplaced during coronal restorations. Symptoms, they can be acute with periodontal abscess formation, which can be associated with pain, swelling, pus exudate, pocket formation and tooth mobility. More chronic response may sometimes occur without pain, which involves sudden appearance of pocket or exudation of pus. This happens generally in root fracture cases. Primary periodontal disease with secondary endodontic involvement. That means the lesion progressed from periodontal pocket and then it continued and involved the tooth through lateral canals, accessory canals, furcation canals and through apical foramen. So, in this, the pulp may secondarily become infected and lose its vitality. So, in single rooted teeth, generally the prognosis is poor, but in molar the prognosis is better because there is not all the roots that suffer from loss of support. If loss to periodontal disease occur, then pulp necrosis is about to occur. So, we have to endodontically treat the teeth, that is root canal should be performed first, then periodontal intervention should be carried out. True combined diseases where they occur simultaneously, but it is less frequent and it is basically the degree of attachment loss is variably large and the prognosis is guarded. Especially if it affects the anterior tooth, then the anterior tooth will go for extraction mostly. The prognosis is really poor. In most cases, periapical healing may be anticipated following successful endodontic treatment. The periodontal tissues, however, may not respond well to the treatment and will depend on severity of the combined diseases. The radiographic appearance will be similar to that of vertically fractured tooth. That is, a J-shaped radiolucency can be seen. So this is basically, you can see in the picture, this is a true combined endodontic and periodontal disease in mandibular first molar. There is separate progression of endodontic and periodontal disease. The tooth remained untreated and consequently the two lesions joined together. There was a filling, so it was a endodontic cause as well, but continuous non-treatment of the case led to horizontal and vertical bone loss also. So, the lesion characteristics of diagnostic features of endoperio are primary endodontic and diseases, pain that is moderate to severe, swelling is possible, in periodontal pocketing none unless the sinus tract is formed, radiographic possible, periapical radiolucency can be seen, and vitality it will remain non-vital. In primary endodontic with secondary periodontal involvement, pain will be moderate to severe, swelling is likely, periodontal probing is evident. Radiographs, there is radiolucency from apex to sulcus but decreased crestal bone height. Pulp status is non-vital. Primary periodontic diseases, pain will be non to moderate, swelling will be possible, periodontal pocketing will be moderate, radiograph decreased crestal bone height, and the vital will be vital. The vitality will be, pulp will be vital in periodontal diseases. Primary periodontal with secondary endodontic involvement. It can be pain, it can be none or unless acute endo is there. Swelling might be possible. Periodontal pocketing is severe. Bone loss can be seen approaching the apex and vitality, pulp may remain vital in some canal. Combined periodontal and pulpal conditions, moderate to severe pain, swelling is likely, periodontal probing is severe, connects to the periapex, bone loss extending to the apex, and it is non-vital. Now coming to treatment appraisals and prognosis. The treatment appraisal and prognosis, it depends primarily on the diagnosis of specific endodontic and periodontal diseases. The main factors to consider for the treatment decision making are pulp vitality, type and extent of periodontal defect. Diagnosis of primary periodontal disease and endodontic disease, they presents with no clinical difficulty. On the other hand, in a tooth with primary periodontal disease, the pulp is vital and responsive to testing. However, primary endodontic disease with secondary periodontal involvement, primary periodontal disease with secondary endodontic involvement, or true combined diseases, they are clinically and radiographically very similar. The prognosis and the treatment of each endodontic and periodontal type varies. Primary endodontic disease should only be treated by endodontic therapy. Good prognosis is to be expected if treatment is carried out properly with a focus of infection control. Primary periodontal disease should only be treated by periodontal therapy. In this case, the prognosis depends on severity of the periodontal disease and the patient response. Primary endodontic disease with secondary periodontal involvement should first be treated with endodontic therapy. Treatment results should be evaluated in 2 to 3 months and only then periodontal treatment should be considered. This sequence of treatment, it allows sufficient time for initial tissue healing and better assessment of periodontal condition. It also reduces the potential risk of introduction of bacteria and byproducts during initial phase of healing. Primary periodontal diseases with secondary endodontic involvement or true combined diseases that require both endodontic as well as periodontal therapies. The prognosis of primary periodontal disease in secondary endodontic involvement and true combined diseases, they depend primarily upon severity of periodontal disease and periodontal tissue response to the treatment. True combined diseases, they usually have more guarded prognosis, in general assuming endodontic therapy is adequate. So basically, the larger the part of the lesion which is caused by root canal infection, the more favorable will be the prognosis as for regeneration of the attachment. Thank you.